Ruth, are you okay for me to begin?
We are, yes, we've just started recording, and I'll let the member of the public who is in the lobby into the meeting.
Thank you very much. Okay. Matinvar agus Falcha, good morning and welcome everybody to this board meeting of NHS Highland. It's lovely to see you all this morning and seeing a bit of sunshine in people's windows. It's lovely as well. I'm sure it's very welcome. So welcome everybody, particularly to members of the public and the press who have joined us today. Just a little bit of housekeeping before we begin our business. You'll see, hopefully on your screen, that this meeting is being recorded, and that is so that it can be uploaded to the web for people to look at a later date, should they so desire. In these meetings, we don't use the chat function at all. So if you wish to ask a question or make a contribution, I would ask that you use your hands up function within Teams, and I will come to you in due course. And I think we are pretty much ready to begin. So I'll just check in. Ruth, do we have any apologies today?
Thank you, Sarah. Yes, we do. We've got an apology from Gaynor Roger and an apology from Tim Allison. I'm conscious also that Philip McRae will be late in arriving to the meeting. So in relation to Tim Allison's absence, we have Nicola Shinea and Liz Smart who are attending today's meeting to answer any public health queries. Thank you.
Fantastic. Welcome both. Nicola.
Morning, Chair. Good morning, everybody. I'm pleased to be here after so long. Just to clarify that due to some change in our work schedules, it'll be only me representing Public Health today, and Liz Mart is not attending today. Thank you.
We will make a note of that. That's good to know. Okay, and do we have any declarations of interest, please? Alistair.
Yes, thank you, Sarah, and good morning, everyone. I had considered making a declaration of interest in my capacity as a Highland councillor, but having applied the objective test and examining my status in relation to the items on the agenda, I feel I don't need to do so. Thank you.
Thank you, Alistair. We'll note that. I'm not seeing any other declarations, so I will move us on. So we are on to item 1.3. This is the minute of our previous meeting held on the 28th of May and the associated action plan. So I'll take the minute first. The minutes in front of us today for approval. I'll just pause in case anybody has any amendments that they think need to be made before we do that. No, okay. Are members content to approve those as an accurate record of our meeting? Yeah, okay, good. I'm seeing thumbs up, so those minutes are approved. And if we could turn now to the action plan, which is the spreadsheet. Sorry, I'm just trying to get that open myself. So we've got 2 items on the action plan, which are both proposed for closure. Oh, there we go. Sorry, I was just waiting for that to open up for me there. So we had action number 17 and 19, and they are both proposed to close. The first one because those updates are now included within the IPQR, and the second one because those pre and post mitigation numbers are being reviewed within FRP and also within clinical governance. But I'm happy to pause there for a moment. Ruth, I don't know if there's anything you need to add at this point.
Thank you, Sarah. No, there's nothing more to add. Thank you.
Okay. Are members happy that we close off those 2 actions, or anybody got anything that they want to add at this point? No, I'm not seeing any other hands up. So we will close off those 2 actions from the action plan. Okay, good. And before we move on any further, I'll just take a moment. Does anybody have any matters arising from the minute that doesn't appear elsewhere in our agenda? Obviously, we've got lots of things coming up for future discussion, but just check that there's no other matters arising before we move on. No, lovely. Okay, well, that takes us on to item 2 of the agenda, and I will invite our Chief Executive, Fiona, to take us through her update to the board. So, Fiona, over to you.
Thank you, Chair, and good morning everybody who's joining us for this NHS Highland board meeting. Just a brief update from me. I've continued to have a period of sustained busyness, combining induction and familiarisation visits, oversight of ongoing and developing improvement programmes, and areas of emerging policy change and areas of government focus. So one area of policy change is the recent amendment that's been tabled within the National Care Service Bill to remove the lead agency model of health and social care integration, currently only utilised in the Highland area. A paper will be presented later in the meeting to outline this step within the bill's journey. A topic which has been a local focus for several years, delayed discharges, has become central in a renewed mission by Scottish Government to reduce delayed discharges to levels from pre-COVID times. Local teams have been aligning their ongoing work to those new government requirements to show progress across the root causes of this complex issue. And that's within our hospital settings as well as our community settings, so that we have coordination across the whole system in terms of our response to what's needed to improve our position. I would offer my thanks to all of our staff that work day in, day out on trying to improve our delayed discharge position through our existing programmes. But I would also say a thank you to those that are in leadership who are trying to find new ways of ensuring the level of coordination and the depth of impact of those actions can be felt further to see an improved position through the rest of the summer and into the autumn. Vaccination improvement work also continues, and my thanks in particular go to colleagues in Public Health Scotland who have recently shared their peer review with us, utilising their subject matter expertise to highlight areas for NHS Highland to focus our improvements in. Services in Skye also continue to be my focus, with increases in advanced nurse practitioner availability being started in July, and I'm meeting with the community with colleagues from Scottish Ambulance Service tomorrow to continue our ongoing dialogue about the expectations that were agreed to through the Sir Lewis Ritchie recommendations. Moving on to marking contributions from our staff, I should mention that my predecessor, Pam Dudek, has been awarded an OBE for services to NHS Scotland, and our warmest congratulations go to her. We've also made the announcement of our latest cohort of winners of our Value in Practice Awards, and congratulations and our gratitude go to all those winners who were noted in my report. I'll pause there and I'm happy to take any questions on my report, Chair.
Thank you, Fiona. And opening up for questions. So I will take Susan first and then Graham. So Susan, I'll bring you in, please.
Thank you, Chair. And Fiona, just relating to your visit to Mull to open the helipad, that was, as you say, a great collaboration there. John Wilson, who cut the tape for us and was a leading light behind making that happen, sadly died 2 weeks ago, aged 94. So glad he saw it opened after many years of campaigning. His funeral is tomorrow. I'll be attending in a personal capacity, but I'll certainly relay condolences on behalf of the board as well. Thank you.
Thank you, Susan. Yeah, absolutely. I wasn't aware of that. So yes, please we pass on our condolences. And as you said, very pleased that he was able to see that after all his commitment to it. So that's heartening to hear that. Okay, Graham, I'll bring you in next, please.
Thank you. Good morning. Fiona, thanks for your update. interested on the point about the delayed discharge, or really beyond that. Obviously, we understand that that's an issue and will be impacting on blockages and delays and so on. But it would be helpful to get an update from you on what the other key pressures are, not just delayed discharges. What are the other challenges that are facing us, both locally and nationally?
Thanks, Graham. I mean, that's quite a wide question, and I think that some of the issues that are impacting us are some of those root causes within delayed discharges. So we know that availability of workforce is a really significant pressure across NHS Scotland and within NHS Highland, and that's not just in our health delivery, that's in our social care delivery as well. And trying to have the right staff to do the things that we've said we're going to do to ensure we care for people in the right time and in the right place, and complying with the safe staffing legislation which has been introduced this year, which is so important for the well-being of our staff, is a very difficult balance. And I think we feel those challenges most acutely in our remote and rural areas, where a single post being vacant can mean that a whole function isn't easily available for us in that place. So I'd say that workforce is one of the driving root causes. There's obviously been a big focus within the finance conversation about reducing our utilisation of supplementary staffing, because we know that that has a significant financial as well as quality impact in terms of the continuity of care that we deliver to people. But we're trying to square the circle of ensuring that we keep services going, that we have things that are running that people are expecting in their areas, but we want to do that with permanent with staff. So there's lots of work going on with our partners through the community planning partnership to look at how we can secure changes to the way we do training, the way that we house people, and the difficulties that that can cause us in attracting workforce. I know we've talked about this in the IJB previously, and we've talked about it within board as well. But those pressures then of workforce affect how quickly we can get through our surgical waiting list and our planned care schedule, as well as the impact on unscheduled care. So the root causes that impact delayed discharges tend to be the same root causes that are causing that pressure through the wider system. Our colleagues in our emergency departments are often talking to us about the difficulties they encounter in trying to move patients through the department in a timely way and into hospital beds or into other places where care needs to be delivered to individuals. So we know that whether it's as we would say, a front door service, a service in the hospital, a back door service, or services in the community, they're all experiencing similar pressures from similar root causes.
Thank you. Thanks, Fiona. Yeah, and I was just going to say, I think it would be good to hear at future meeting, just are we making locally and nationally, are we really making any progress on workforce? Because it just seems to have been a perennial problem, obviously, and I think it would be good for us to know if there's any light at the end of the tunnel on that at all. Thank you.
Thanks, Graham. And Fiona, I wonder if I can just build a little bit on Graham's questions there, or points around delayed discharge. Taking into account, we're talking about the root causes, and you've quite rightly described that those pressures that affect lots of different parts of the system. I suppose I'm also mindful of bits outside our system. So we've seen the pressures that the independent sector has experienced, and we've seen that through care home closures, and obviously there are bits of that whole system that sort of sit outside our immediate control. And I just maybe wanted to hear you speak a little bit about conversations that maybe are taking place with partners in other sectors around that, and how that's coming out nationally. I suppose to say I really welcome the national support and focus around delayed discharge, which obviously we've been focused on it for a long time, but having that national focus on it is a really important thing. I think what's also going to be important for us going forward, as well as looking at the the number of days that we talk about in delayed discharge is the patient experience and the length of stay, recognizing that we won't be able to just switch a tap on and off and make it all go away overnight. So looking at that qualitative element that people experience, as well as just the days and the numbers, if that makes sense. Thank you.
Yeah, thank you, Chair. If I take the second part maybe first, we were just hearing yesterday from colleagues who oversee our community hospital that for patients who aren't in delay, the average length of stay is now down to approximately 7 days, which for people who are maybe later in their years and needing ongoing care arrangements, I'd say that that benchmarks favourably. So where we are able to ensure that there's an onward destination for somebody, that people are getting a good experience, but we know for those that have delay that experience wouldn't be as positive. But as you say, what we want is to provide our own services to a high quality. But I think as a board, we also have an obligation to try to create a thriving environment where NHS Highland works with loads of partners to deliver services, whether that's our drug and alcohol partners, our services where we work in partnership with older people, younger people. We can't do this by ourselves, and we wouldn't want to. That plurality of provision brings such great benefits in terms of different types of approaches, different styles that can be so beneficial to different people at different life stages or with different kinds of challenges. The NHS is only one of a family of services that meet people's needs, and we want to do what we do well, but we also want to encourage others to be doing well, and we rely on our partnership boards, our joint monitoring committee and the relationships we have with the council, but our drug and alcohol partnership, our community planning partnership. So our ability to work well in partnership, I believe, is what's going to give us strength to create those relationships where other organisations are also thriving in a Highland and in Argyll and Bute context, which will give us that plurality and the range of providers that can meet lots of different needs, and that can be done in the different ways that are going to improve outcomes for people.
Thank you, Fiona. Okay, I'm not seeing any other hands up. I suppose just before we move on, I wanted to say I'm very supportive of the work that you've done, Fiona, to get out and about. I know, we have a very large board area with some challenging transport infrastructure to negotiate. So I know firsthand that that's not always quick, simple or easy to do, especially when there are lots of pressures on the system. But I'm very pleased to see that you have been getting out and about, and I look forward to joining you on some visits later this week as well. So that's very positive, thank you. Okay, I'm not seeing any other hands up for comments or questions following Fiona's update, so we're being asked to note that. Thank you, Fiona. So I'm going to move us on now to our committee assurance reports from our various governance committees from the chair. Now, first up, we have audit committee from the 18th and 28th of June, but as Ruth advised, we had a last minute apology from Gaynor, unfortunately. The minutes are in front of us. People will have had the opportunity to look through those minutes. I don't know if any other committee members who are present, I'm happy if you wanted to add any sort of flavour and context to those minutes, but otherwise we can take questions, and if necessary we can take them offline and pick them up with Gaynor to come back at a future date. I will pause momentarily if anybody wants to come in at this point around the audit minutes. Okay, I'm not seeing any hands up at this point for the audit minutes. We can of course pick up anything out with or at the next meeting where necessary. So I'll move us on to the minutes for FRP. We've got two sets of minutes here from the 14th of June and the 5th of July. I'll invite Alex in at this point. Alex, for any highlights that you wish to bring to our attention in addition to the minutes in front of us.
Thanks, Jen. Morning, folks. Yeah, a couple of things. The meeting on the 14th of June, probably the most important bit was that's when we got the full financial for last year. So we ended up with a 29.5 million brokerage from the Scottish Government, to balance the books, which was a great improvement from where we were. So the team had done remarkably well to bring that down to that number. We then talked a bit about the budget setting for the following year, and the bit that was of concern, and we had a lot of discussion around, was the issue about the proportion of financial risk highlighted from adult social care and delegated services. And what we agreed there was we would actually put a board risk in place, and I'll quote the risk. There is a risk that NHS Highland will not deliver its planned position of financial balance within the adult social care delegated budget for 2024 due to the current underlying financial position, representing a significant overspend against the allocation received, with an opening deficit of 16.252 million, further reduction in the relevant quantum of 7 million, and an inability to realise a 3% reduction in spend in line with the value and efficiency plans of 5.71 million. So that's a risk that now sits on our risk register. We'll continue to work, as Fiona mentioned, with our partners in NHS Highland, and we will monitor the financial position as we go through. That was probably the one bit that I wanted to highlight from that particular meeting. The meeting on the 5th of July, the draft minutes are out. There, again, you can see the financial challenges that we face. We've already got an overspend of just over 17 million, which is forecast to rise to 50 million. Bearing in mind that our actual financial cap is held at, I think it's either 27 or 28.5 million, around that. So you can see that we've got real challenges that we face in that situation. Again, the team and the board will be working closely to try to minimise that as we go through the year. That's it, Chair. Thank you. Any questions?
Thank you, Alex. Yeah, and obviously we've got our substantive paper on finance later on in the agenda, but it's helpful to see the work of the committee in a bit more detail. Susan, I'll bring you in next, please.
Thank you, Chair. I'm sorry, Alex, I'm just going to take you back a bit, if I may, because there were two audit meetings that were included. And when you moved on, I thought you were going to move on to the second one. So there were meetings on the 18th and the 28th of June. So the second audit meeting contained the external auditor's report, which was a clear and unmodified report. So just drawing that to people's attention, there are reports from two audit meetings before the final one. Thank you.
Sorry, Susan. Yes, you're right. I should have made that clear that we had the two. Obviously, with Gaynor not being here, so we'll noting those two minutes. Apologies, I should have made that clear before I brought Alex in.
And again,
any other
to highlight what Susan said, the fact that we got that from the external auditors was very good. That's an improvement from where we were last year. So that's a definite benefit. Thanks.
Okay, any other questions for Alex at FRP? No, I'm not seeing any other hands up. Thank you, Alex. Next up, we have the Staff Governance Committee. So the minutes there from the 9th of July. And I will invite Anne in, please.
Thanks, Sarah. I'll just run through a few highlights to draw the board's attention to. We scrutinised progress with a number of key work streams at this committee. We took only moderate assurance on our progress in terms of Statman training improvement, as we're experiencing some delays in taking forward the actions relating to face-to-face training, and that's due to the additional workload that we've had as a result of the non-pay elements of this year's settlement, and also the Safe Staffing Act that Fiona mentioned earlier. There has been a small improvement in the online completion rates, and we'll continue to monitor that closely. And I think that one of the key things we're trying to do in the committee at the moment is to draw on the range of executives that routinely attend staff governance to try to encourage the wider organisation to help in this mission of improvement in this area. As you'll have seen in the IPQR, our time to fill rate for recruitment remains elevated, and it's well above that of the best performing board. So there's a lot of attention being given to this to try and determine the root causes. One of those is the significant increase in the volume of overseas applications since job application went online. And unfortunately, I think it may be that a longer term and more fundamental change in our approach might be necessary to get a significant improvement in this metric. And that would inevitably take time, but we're following that closely. And then finally, I think in terms of alerting the board to issues, we had a report on the overall progress with the people and culture elements, which highlighted some difficulties in resourcing our ambitions around leadership and management development. However, recruitment is in progress, we're assured, and people are being encouraged to take up the various options on offer. Obviously, that work's crucial to our ambition to be a great place to work, and we've got a full report on it scheduled later in our work plan. We received 2 reports from which we took substantial assurance, but they're on the agenda today for the board, so I won't dwell on those. And I can also advise the board that we approved the next 3-year communications and engagement strategy. And I think all of the committee commended the whole team there for making the absolute best of some very limited resources. And we're looking forward to getting our usual 6 monthly updates on that as the work progresses. And then finally, as usual, we had our learning session and our spotlight session, where this time we heard from the Deputy Chief Executive about the e-health strategy and transformation and resilience teams. And certainly we got some very interesting run through the work being undertaken by our exceptionally skilled but tiny resilience team in improving our organisational resilience in the face of events such as extreme weather. So that was a very interesting presentation. So I think I'll stop there, but happy to take any questions.
Thanks, Anne. Yeah, I really enjoyed the presentation from the resilience team as well. It's one of those functions that you don't know it's there because they're pedaling away in the background, pulling it all together, but it was very impressive. Thank you. Okay, any questions for Anne or any comments? No, okay, thank you, Anne. And as you said, we've got a couple of substantive items later on that we'll pick up in more detail. Next, I'll ask Jerry to speak. So we've got the minutes of the Highland Health and Social Care Committee from the 10th of July. So Jerry, any highlights for us?
Thank you very much, Sarah. I'll just pull out a few items from our meeting at the beginning of July. Board members will note from the agenda that we actually took items 2 and 3 almost as one concurrent or one consecutive agenda item, finance and transformation. So we looked at the closing position in 23-24, which Alex has already picked up on there in terms of the Finance and Performance Committee, just to understand exactly where the partnership finished the year end in terms of that, and whether there was any lessons or anything we could take forward into 24-25. We then looked at the draft financial. We then looked at I think it was at that point still draft position financial plan for 24-25 and the scale of the challenge in presenting to the board, and we obviously particularly honed in on the partnership requirement there. And really what we were trying to achieve through the session, we devoted, I mean, probably about a third of the meeting we put into this rather meaty topic. Was really just to get all the committee members up to speed and understanding exactly where we were, which I think was really important to actually understand the many moving parts which are actually in pulling together the finance position in terms of the savings target, the adult social care position, and I think importantly, and we'll talk about this later in the agenda, delivery against operational budgets, which is going to be a challenge in of itself this year because we're already seeing pressures. So I think we had a really good session there, and then Pam finished it off by taking us through a high level of the savings and transformation plans as they were sitting at that date, and we will explore them further through the Finance and Performance Committee as we move through the year. So a really good session there. We received a few update reports in terms from learning disability and primary care. And I think although there was challenges in both of those reports in terms of delivery, I think there was some good work, which is to be commended. And I think it's really important that we don't always concentrate on the challenges. We have to actually look at the positives and actually take heart from that and just recognise the excellent work that lots of most of our staff are actually taking forward. I think within primary care, particularly, we should be looking at the extension of the community link workers programme, and we've now got input to all of the practices, which I think that is really such a positive there. Adult protection, we got a good update to the committee there. I think one of the things we've noted there is really there has no reduction in the service demands in adult protection now post pandemic. We obviously saw a spike in adult protection issues during the pandemic, but that activity seems to have plateaued, and that's obviously putting then demands on our social work colleagues, and that's feeding it through. Chief Officer's report almost mirrored the report that Fiona has given us earlier in the agenda in terms of the key issues, vaccines, people experiencing delays in the National Care Service, and we will cover them again. We asked for a substantive report to the next agenda on Health and Social Care Partnership on vaccines, because we'll be in September then, so we really should be approaching that crux point for the winter programme. But those were the key points. Sarah, I'm happy to take any questions or expand further. Thank you.
Thank you, Jerry. That's really helpful, and obviously that vaccines report will be really timely as well, given the update that we had earlier around the options appraisal work. So that will be well timed and a really important item for the committee to look at. Happy for any questions or comments for Jerry, and also just to pick up, Jerry, the fact that you said you did that sort of detailed look around the finances and tying that back to the risks that Alex identified in his update. So those two things tie together neatly. Good to hear. Well, not good to hear, but assured to hear the level of scrutiny that's gone in around that, as you would expect. Okay, not seeing any hands up for Jerry at this point, so we'll note that. And who have I got next? So I've got Clinical Governance Committee of the 11th of July. And I'd like to ask Joanne for any updates. Alistair was away. So Joanne very dutifully stepped up and took that one meeting. So I don't know, Joanne, if there's anything you want to highlight for us.
Thanks, Sarah. We had a very full agenda at the meeting and covered a lot of topics with some really good discussion. The areas that I'd like to highlight today are NDAS and the vaccination service, which had limited assurance for both. Whilst we noted the ongoing work that was going on, we have requested further reports to come to the next meeting. And that's really the two parts that I'd like to highlight today. So any questions I'd be welcome. Thank you.
Thank you, Joanne. And obviously those two items have been areas of focus for the committees, a number of committees, and the board as well. So we look forward to seeing the fuller update at the next meeting. I think that's very helpful. Any other contributions or questions around the clinical governance update? No? Okay. Thank you, Joanne. Oh, sorry, I've lost my place. And next we have the Area Clinical Forum, which took place on the 4th of July. So Katrina, I'll ask you to come in at this point with any highlights for the board.
Right. Thanks, Sarah. Yeah, that was our first meeting since March. We'd had some COVID problems up to that point. But it was quite a well-attended meeting considering it was the start of the school holidays. It was our first chance to update the forum on the joint development session which we'd held with the board on the quality framework, and a really good opportunity to share thoughts about how that had gone, and very positive feedback. People had enjoyed the face-to-face session, the chance to meet board members, found it really interesting, the diversity of experience and therefore opinions that could be shared, and generally we're keen to have another event as appropriate in the future because they felt it was time well spent. And at the moment when clinicians say it's time well spent, I think that truly is time well spent. It's a very good reflection of the quality of the day. So and how the organisation of the day. So thanks to all those who helped organise that as well. It was one of these meetings where we got more information to us than we were sort of sharing back, but it was all really valuable. Our new director of psychology, well, fairly new, Alison Turnbull-Dukes came along, and Alison gave us a really good update on psychological services, which was really worthwhile. Well engaged with lots of questions, because obviously psychological services impacts on almost every other clinician in the room. So it really was very worthwhile, and I think it helped. It was very timely update for us all, which was excellent. And then as our main section of the day was part of the active engagement with the blueprint for good governance. So part of what we were hoping to do for our development as well is we were getting the update on the financial plan and the ADP. Now, the ADP wasn't ready for us, but we will have that at the next meeting, we hope, now that it has been sort of agreed. And we had the finance plan, and Helen and Gareth came along and were very honest and very frank with the information they shared, which was, again, I think that it was a relaxed, open session, and that was very much appreciated by those present. And a lot of good questions. It ran probably a wee bit longer than we'd anticipated, but it was, again, really quality time well spent. And I certainly would thank Helen and Gareth for the input they had and their willingness to be very open in the conversations and the answers that they gave everybody. And we look forward to the ADP part at our meeting at the end of August. But very good. As I say, a lot of information coming to us, but I think it was really good because it was time. We'd probably needed a lot of that information to reset any priorities for the coming months. So it was a good meeting. Yeah, thank you.
Thanks, Katrina. And I suppose just recognising the point you made there about quality time well spent, I would echo that. I think that the time that we spent in partnership within that development time with the members of the ACF was really, really valuable. And I suppose that pressure on time has been illustrated by the challenges you've had with some courtesy in the last few months. So it's really good to hear that the ACF has managed to come back together. And that sounds very positive, and we'll continue that engagement. And of course, you know, members of the board are able to attend that as well, which keeps that link in place. And I think that's really important going forward. Happy, any questions or comments for Katrina for the ACF? No, lovely. Thank you, Katrina. And next I have the Argyll and Bute Integration Joint Board meeting of the 29th of May. And I'll invite Graham for this one, please.
Yes, we too had the excitement of an in-person meeting, which was great. It does make a difference when you get them from time to time. Sure, none of us would be wanting to do it all the time now, but it certainly was a very good meeting. The clue, of course, is in the name. It's a Health and Social Care Partnership, and it gave our in-person meeting gave our new chair, Councillor Dougie McFadgen, the opportunity to meet people in person, and he's certainly hit the road running. And it's really good to build on that sense of partnership that there is in the area. And also to note that, you know, the third sector and the private sector were represented as well. And, you know, that gave good opportunities for both the problems and the opportunities to be discussed wider. Obviously, close working can have a downside as well. You know, one of the issues that we touched on and has been touched on since is the difference in recruitment times that there is between council and NHS, which is, you know, quite dramatically bad from our point of view in the NHS compared to what's happening, and that can cause frustration locally. Some of the other areas we talked about, finance, the partnership is working towards a balanced budget this year, but we're under no illusions. A lot of that balance happens because we have some chronic issues with recruitment of staff, and you know, that kind of dilemma for us as an organisation was faced, that you can meet your budget, but there's a price to that as well, and so that's one of the dilemmas that we also have. We also touched on the issue of the big chunk of services that that within the Health and Social Care Partnership are effectively dealt with by Greater Glasgow Health Board. So, you know, around half the population are dealt with services there. We had a bit of a discussion about that. We're trying to open up what we understand and how we can become more involved in that. And one final area was we mentioned about what kind of oversight governance do we really have of the primary care services within the area. I guess that's one that we'll be returning to. But a good meeting and folk working well together. So that was happy to report. But of course, it was 2 months ago. So our next meeting is in August due to the council holidays. Thank you.
Thank you, Graham. And I suppose I just wanted to pick up a couple of things there about you touched there on the governance around primary care, and of course that's slightly complicated by the fact that, you know, clearly we have contracted services, but also we have 2C practices as well, which sit within board responsibility. So it's a mixed picture, and I know you and I have spoken about that in other forums as well, so we will keep that going. And I just wanted to ask, actually, because you prompted me there, and this is maybe either a question either for Evan or maybe Fiona. We have talked for a long time about, I suppose, a reset or a review and reset of the service level agreement that we hold with Greater Glasgow and Clyde for those Argyll and Bute pathways. And I know that is a long and complicated conversation. Of course, it's not just one SLA, is a number of different agreements, but I just wondered if I could get a very quick update on where those conversations are currently, or where we think they're headed. Thanks.
I'll defer to my professional colleagues, the ones that really know what we're talking about, I hope.
I'm not sure actually if Evan, I think Evan is possibly having to dip in and out today, so Fiona, I'm afraid that might fall to you.
Yeah, and I'm not sure I can give you the very latest position. Certainly when I was in the Argyll and Bute Chief Officer job, I took the lead on creating an exec-to-exec conversation with a nominated executive director in Greater Glasgow and Clyde to look at some of the service issues that had emerged through the COVID period, and maybe the existing previous arrangements had fallen away, in ensuring that those were aligned. But we also used that opportunity to start to look at some of the strategic issues. For assurance, the planning function within Argyll and Bute worked really closely with the planning function in Greater Glasgow and Clyde, and indeed in the West Regional Planning Group. But I think it would be fair to say that there is some anomalies within that because of board arrangements in other boards not crossing regional boundaries. That is a complexity that we still haven't completely overcome. So the National Planning Board has now been established, and one of the things they're looking at is looking at what should be in the scope of regional planning in a refreshed way. So I've used that opportunity to prompt national colleagues to be thinking about the regional challenge we have of working across these two regional boundaries. But that doesn't preclude conversations directly with Greater Glasgow and Clyde. So you probably need Evan to get the very latest of where those conversations have got with the link director. But certainly within my induction period, my intention is to pick up a conversation with the chief exec in Greater Glasgow and Clyde, and Jane Grant has announced her retirement, so I'll try and do that before she heads away. But as ever, a change of leadership is also an opportunity sometimes to reset relationships. So I think there's an opportunity there too.
Yeah. Can I maybe just
come on, Graham, yeah, of course.
add, it's important to say that it's not all problems with Glasgow. You know, many things, as Fiona said, many things work very, very well. And, you know, there are loads of interactions, many interactions taking place every day that just run like clockwork. So, you know, we wouldn't want to kind of misrepresent the situation either. And our geography does mean that, you know, we're kind of difficult to try and find out which is linked to where. There, I think Susan will remind me, will keep me right about this, but there was a discussion, I can't remember whether it was at IGB or at the a visit Susan and I went to Cowell, but it was around the links between Oban and Fort William. And, you know, there was a discussion about how, given the geographical proximity, we wondered whether the boundary issues there were maybe artificial in a sense. And there was a kind of a question that we're looking to explore in the future about, you know, how much Oban links to Fort William and vice versa, and capacity use and so on. Anyway, sorry for going on a bit. That's it.
No, that's really helpful, Graham, and absolutely to reflect, you know, definitely not all bad. I have some first-hand experience with some very excellent services from Greater Glasgow Clyde, so you're right, it's not all negative by any means. Louise, sorry, you wanted to come in?
Yeah, and it's just to be cited on the fact that where we have got some challenges, I know the team have been very proactive in looking at alternative solutions. So certainly there's some discussions about pathways into Highland for a couple of services that are being actively explored. So I think it isn't just about if things aren't running smoothly, we just accept they're not running smoothly. We are looking at alternative routes as well.
Thank you, that's helpful, Louise. Okay, so that brings us to the end of our committee assurance reports. So just to recap, we are being asked to confirm that we can take adequate assurance from our board governance committees, and as we noted the minutes and the update from Graham around the Argyll and Bute Integration Joint Board. Everybody happy with that? Yep, great. Thank you very much. Okay, I'm going to move us on now to item number 4. So I will invite Heleth to speak to this one. This is our finance assurance report on our month 2 position. So Heleth, I will hand over to you, please.
Thank you, Chair. I just wanted to start by actually picking up on the point that Alec made around the 23-24 position. I suppose we haven't really closed that off formally at board. So just to confirm that the audited position and the signed off position was unchanged from the position that was presented at the last board meeting. So there were no changes needed through that audit process. So that's really positive. Thank you. For month 2 finance position, the agreed position at the last board meeting was a set budget with an anticipated deficit of 50.6 million, which is 22.2 million above the brokerage cap, which is set at 28.4 million by government. But with a commitment to reduce the gap where we can throughout the year. The position is predicated on 4 key actions. One is the delivery of 3% recurrent cost reductions, which is an expectation across all boards in Scotland this year. As is already mentioned this morning, delivering a break-even position at Argyll and Bute. Similarly, delivering a break-even position for the adult social care budget. And then finally, just maximising any financial flexibilities that we have through allocation management and slippage. So the month 2 is the first reporting month of the year, and therefore we're still putting systems in place to capture some of the data around our plans, especially the cost reduction plans. And there may be some hangover from the 23-24 position, as well as we have some over and under accrual. So it can be a slightly tricky month. But it is indicative of the direction of travel. At the end of month 2, we've reported a deficit position against the budget of 17.364 million, and we continue to report a forecast of 50.682 at the year end, but this is on the assumption that the 4 key actions that I've just mentioned are delivered, and recognising that 3 of these in particular hold either a moderate or a high risk of not achieving them. So it is challenging, but we do need to continue at this stage to assume that we will deliver that. Some of the key highlights to draw out are the fact there is no plan currently identified to close the 16 million gap in adult social care above the 3% cost reductions. We are seeing some reductions in allocations as they're coming through, so that's posing a risk to the organisation, and we're having to realign some of our plans to deliver within the new allocation that we're receiving. We're already seeing some pressures within drugs and prescribing, with increases in both the number of items being prescribed and also the cost per item. Our agency and locum spend remains high, but we are seeing reductions and conversion to bank shifts, which is through the value and efficiency work streams. There's a lot of focus in this area. And within the report, the savings target currently sits centrally, so it's not been allocated out to the services. Within the capital position, we've had notification of our core funding of 6.947 million, and so that's confirmed. And then with the additional expectation and anticipation of additional funding for the completion of Granton Health Centre and some additional funding for EV chargers. We are including within our monthly finance returns highlighted additional commentary around the cost pressures for backlog and maintenance within capital and the impact of the capital pauses. And we will be picking this up as well within our quarterly finance meetings with Scottish Government, alongside some of the other pressures that we have. So that's the majority of the detail. As you can see, we are providing limited assurance, and that's due to the deficit that we are currently reporting and the gap from brokerage. And I'm happy to take any questions.
Thank you, Heleth. And obviously this is all scrutinised in a fair amount of detail at our monthly FRP meetings, but I am happy if people want to bring in questions or comments around any of the updates that Heleth has shared today. Because I've got a couple of questions, and again,
I think Sarah's frozen for
sorry,
me, so Emily, do you want to come in?
Thanks, Sarah. Did you want to go first now that you're back?
No, go for it.
Thank you, and thanks, Heleth. I guess just from a sort of realism point of view, you mentioned in the SBAR that there's further plans being developed to generate additional cost reductions and improvements, but given that we're already partway through the year, we're not going to see the full impact of those. So is there really likely to be much improvement from the current position? And I appreciate you giving limited assurance, so potentially not, but that was just an observation really of the fact that we're not going to see a full year impact of anything that's not already planned. And secondly, just around prescribing and supplementary staffing, I appreciate this has probably been covered at FRP, but I'd be interested in a bit more detail, potentially offline, around the specific actions that are being taken on those, because they were big areas of plan saving. I know that we missed targets on those last year, and it seems without system change that it's not likely we would make a huge difference to move the needle on those areas, just because the underlying problems like lack of resource, etc., are not just going to go away overnight. So yeah, apologies, that's slightly long-winded, but hopefully that makes sense.
Yeah, that's fine. Thank you, Emily. We're constantly trying to look for new ideas and new areas, because we do have plans for, we'll have to make reductions next year as well. So the sooner we start on those, the better. Our focus for this year is on the 3% efficiencies. That's where we really do need to deliver, and deliver recurrently as well. So we're seeing the benefit into the future years, where we've tended to make our efficiencies and reduced our position in previous years has been non-recurrent actions, taking benefits from balance sheets and additional allocations and such forth. So we really do need to change the stem of the the flow of the tide, I guess, if we can say it that way. So you're probably right that there would be limited impact in this year, but the intention is that we would see some benefits next year. And we do have to be mindful of the capacity that we have internally to deliver on lots of different things as well. So we are focusing on the value and efficiency programs that are delivering the 3%. And that, I guess, ties into your next question around prescribing supplementary staffing as well. So that's where those programs sit. We've had a presentation at our bi-weekly meeting for value and efficiency around prescribing, working through some of the actions they're taking. So both, there's a big programme of work happening out in primary care, and there's another programme of work happening within acute, and then there's some work that's happening across the two as well. So there's a lot of work happening within that space. Our assumptions within the planning process was that there would be increases within prescribing of drugs anyway. There always are, so that was part of the plan. The cost reductions is pretty much trying to offset that growth to kind of keep it as a balance. But there's, even within that, our cost reduction plans are less than the assumed growth. So there was still a net expected increase within drugs and prescribing. So we currently are delivering changes within prescribing. So some of those actions, especially around switches of medicines and moving to generics, they're happening. But there's, I think, just a little bit of nervousness about over-promising on drugs savings through the year. So we're probably not forecasting the full benefit that we should make this year at the moment. And hopefully that will become a bit strong as we go through the year. We're still a bit early days and people are still kind of testing their way through that as well. And we've also had some new people join the organisation. So we've got a new director of pharmacy. So she's obviously putting her own processes and is just a little bit cautious around what she'll promise. But we have got an ambitious target within prescribing. Supplementary staffing, again, so Gareth is leading, is the exec lead for the cost reductions, but we've got CIROs, we've got professional and management leads for each of the different areas within acute, within the professional leads, within the partnership and the professional leadership as well. So there's about 6 or 7 different work streams going on within supplementary staffing, and we are certainly seeing some changes. So we're seeing a lot more bank shifts being taken up and a reduction in agency. We can see those hours coming down. We know that we've made progress in recruitment in a couple of the 2C practices around GPs, in mental health in particular. Again, we had the presentation from the partnership yesterday where the leadership in there were clearly stating how much the agency reliance has come down. So there really are some positive changes happening, but they will take time to flow through. And we do have to balance that then against new initiatives that come in from government, and generally, in order to put new things in place quite quickly and on temporary funding, we tend to then rely on supplementary staffing and locum and agency again, so it can mask the benefits and the changes that we have made.
That's really helpful context. Thank you.
Thanks. Just before I bring others in, can I just ask a question that builds on the piece around prescribing, drugs and prescribing? And this is maybe something that we pick up, at an FRP meeting, but I'm actually interested in, I don't know what if you would call it, that kind of the front door process around new drugs coming in. It's fantastic that new drugs are being developed all the time and they come into the system. But with that, there has to be some kind of pathway design to make sure that we understand when and why it's being prescribed, and that's being done in a data-driven way. And I'm happy to pick this up at a committee, but I think it would be something that would give us assurance as a board and as a committee around how we are making best use of the new developments in drugs and pharmaceuticals, but in a controlled way that is in line with our strategy. And I saw, sorry, so I'll leave that on the table unless you wanted to come back on that, Helen. Sorry.
Yeah, I can come back on it. I do sit on the Area Drugs and Therapeutics Committee alongside Boyd as well. So we do put some of that challenge in the conversations, and when new drugs come in, the conversations around them, we do ask, well, what are the pathways and where's the business case that supports it and how does it fit in with other services? So that conversation's happening, but also our Director of Pharmacy is reviewing the governance processes around new drugs as well. And there's a lot of work happening nationally around new drugs and prescribing and access into the market, and how do we make sure, I guess my question is always around, is going to a drug the right solution? Sometimes it is, but sometimes we put a drug in place rather than look at the preventative measures as well. So we do need to have that conversation before we just go straight to the drug solution. But maybe Boyd would have a bit more to add on the technical details of that. But it's certainly from the meetings that I attend, they're the things that we are talking about. So we are really putting some renewed focus on that financial governance around it, but also the pathway management and the outcomes and the benefits.
Yeah, absolutely. And I'll bring Boyd in because I can see he popped his hand up there. Boyd.
Yeah, thanks. Health has covered a lot of it. It's important that prescribing isn't looked at entirely through a financial lens. We need value based efficient prescribing, but also needs to be quality prescribing and the right drugs for the right person, subject to the guidelines that are put out for nationally to govern what should be best prescribing. There are some inefficiencies that could be dealt with, such as switching from a branded product to a generic when it's available and when products come off license. There is also a real boom in new drugs and the costs of those new drugs. And so therefore it's worth noting that this is a unique Highland thing to grapple with, but actually is replicated in all boards in Scotland and probably further afield again. So, but otherwise I think Health has covered it, and we recognise the importance of building pathways, not just prescribing, and the governance piece that has been mentioned, just to make sure the right decisions in organisational terms are being made in terms of oversight of our systems, our pathways, our processes. And so I've asked the Director of Pharmacy to look at that, as it's a good opportunity as she has joined the organisation to give some fresh eyes on how we do things here.
Good, thank you. Fresh eyes are good. Lovely. Alex, did you want to come in on one of the points there, or was it a different question?
I thought I'd unmute. No, it's a different question.
Okay.
I'll leave it to the queue as was.
You can wait your turn. Yeah, that's fine. Okay, I'll bring in Garrett next, followed by Anne. So Garrett, over to you, please.
Yeah, I was just going to raise the phony question of anybody ever bring up the affordability of free prescriptions for everybody? Does that ever get mentioned, or at some point it's going to get to a point that people that can afford to pay it will need to pay it, and prescribing Brufen and paracetamol to everybody when you can buy it a lot cheaper in supermarkets. On the round, we need to have these conversations at some point.
Thanks, Garrett. And I think Boyd. Oh well, either Headless or Boyd. Boyd popped his hand up, but I don't mind who goes first.
I got my hand up this time, and Health has covered a lot of stuff for me. So that's a political thing, and I guess that NHS Highland has to be apolitical. So we probably can't take a position on that specifically. If it's government policy, then it's the duty of the board to enact that policy, with the only exceptions being occasionally of exceptional individualized care that might step outside, for instance. In terms of what I think, what's within Garrett's point, perhaps, is are there some cheap drugs where the prescribing system actually adds cost to government and taxpayer? Broadly speaking, no, that's not where the cost pressure sits, actually, and it's not an excessive burden itself for the examples given. The cost burden is in things like our original drug supplies were European. For changes in political circumstances, some of the sourcing of drugs is different now, and the creation of drugs, production of drugs in factories in the UK is limited, so we have to outsource internationally very often for some of our most basic drugs. So you end up with some of the basic drugs costing a lot more than they ever used to. Antibiotics are a good example, but there are lots of others, and it's because we're having to source them from countries abroad where there are not maybe trade deals, and where costs can be quite high because it's a market economy. We're competing with the rest of the world, and to get these commonly used drugs, you actually you have to pay a top dollar price, and so we have all sorts of variables within the market. And as an NHS provider, of course, we're based on a different sort of market that's built on a public service, but we have to dip into competitive financial and production markets to obtain the products that we need. And that can be a hidden factor people don't think about, as well as the aforementioned new drugs with their very eye-watering costs in some cases, but great clinical potential that they hold.
Thank you, Boyd. I've got a number of other people waiting to come in, so I will bring Anne in next, please.
Okay, so I'm on a different tack. I don't know if anybody else wanted to come in on that prescribing sort of. No, okay. So just a couple of things in relation to the risk that Alec flagged earlier around the adult social care position. So just a point of detail first. I was wondering that on page 52, the report refers to possible improvements in the position once there's some clarification about allocation. Celeste, I was wondering if that's still an open position. Do you have an estimate of the size of the improvement? I mean, are we talking a minimal improvement? A medium sort of size of improvement that would have some impact on the overall position. So I was wondering if you could clarify that, if you can. And then in relation to the more substantial issue around the risk and the assumption of balance in that position, I wondered what the process will be and the timing will be for testing that assumption. Sorry about the dog in the background. So, are we likely to have a clear view on that assumption in the early part of the year, sort of halfway through the year? Is it likely to be something that we're going to be left not knowing until the end of the year? Can you give us any sort of idea on that? Thank you.
Thank you, Anne. The possible improvements, there is a finance meeting between NHS Highland and the council on Thursday where we're just finalising the quantums on both sides. So the intention is that we can work through at least the detail of what's expected through government and flowing through the system, etc. We're hoping, we're anticipating, but please don't hold me to this because we're still working through that detail, but we're hoping that there'll be an improvement there between 2 to 3 million. So that would be positive. And then following that conversation as well, we will be formally writing to the council around their children's quantum, and we have asked that the council does the same. So we will hopefully get clarification on the additional 7 million quantum reduction at that point, because that's not formally come to us at any point yet. So that's the expectation there. So once we've been through that process, we'll at least know what the true gap is. I think the clarity then on how we work through that remaining gap is the bit that we need to do further work on. Obviously, finance is a focus on every meeting that we have with the council. We do have access to the transformation fund that they're making available to us, and the whole point of that is around us putting forward proposals which might be kind of spend to save, I guess, initiatives. So we're working through a few solutions with there. One of them is around tech-enabled care, but we haven't worked through the detail of that yet. So my best guess at the moment, Anne, would be probably around mid-year, end of Q2, we would want to start ramping up a conversation if we haven't really made any significant progress at that point. We can't leave it till the end of the year. That would be too high a risk for the NHS. So the conversations will be going on every month. But I think at the end of Q2, we'll need to take a bit of a stronger position around, right, how do we resolve this and what do we do?
Thanks, Heleth. Okay, I've got Alex next, please.
Thanks, Chair. Yeah, Helen, probably actually it's Richard that's more the person who will have to answer this. When the capital funding was reduced, the Scottish Government said that there was going to be a focus on backlog maintenance. Now, I can see a chunk of money in the States, but I can't see, and maybe it's because it's too low down, is where we are with backlog maintenance. Are we getting the funding for backlog maintenance? Has it increased any? Or are we just chugging along as we were?
I can come in there if you want, Alex. Yeah. So we're waiting for an additional allocation to be made for backlog maintenance, and that was supposed to be considered in the spring. You've probably seen that that's been delayed now until later on in the year. So we've made an additional request. I think we reported this at FRP for the implications from the delayed major capital projects. We're also working on our business continuity plan, which is that collection of backlog maintenance. So work continues on that. So the long and the short of it is, we've been told that we will get some additional backlog maintenance, but we're still waiting to hear what that is.
Thanks, Richard. Okay, I've got Jerry next, please.
Thank you, Sarah. I've got a question which I was actually going to ask under the IPQR section, but given that Helen mentioned allocations, I thought I would sneak it in here. It was just to get a general view from either from the executive team on what is our approach to anticipated allocations. I noticed in a couple of sections of the IPQR the reason for some delay in recruitment being put on to we don't yet know the funding position, and I just wondered where we were in relation to it, because we know we will get something, but I think I picked up from Helen saying some things were coming in less than we had anticipated. So I just wondered what our general approach was to whether we actually say, well, we'll get something, ergo we will recruit, or we wait until we've got a definite answer from policy colleagues at Scottish Government. Thank you, Sarah.
Thanks, Jerry. Heleth, I'll bring you in, please.
Thank you. It's a little bit variable, Jerry, depending on the allocation. So within our budgeting process, there are some allocations that we get year after year, and we have assumed those. So they're within our budget, and therefore the risk is whether we'll get it or not. We did get commitments off government this year that they would provide us with details of 80% of our allocation by the end of Q1. So they did come through thick and fast towards the end of the month. So they were flurrying. I think I was getting 2 or 3 letters a day nearly at one point. So we are in a much better position around our allocations. But we have been holding back on some development until we've had confirmed allocations, because it was just too high a risk for us. But it depended on the allocation. So where there were things where we know there was a reasonably strong understanding that we'd get something, then we would continue with the commitments that we had in place, but we would make sure that there was a bit of a buffer in place so that we weren't committing more until we knew the value of that. So that was the balance we were having to play, and there were some areas where we just stood firm and said, I'm really sorry, but we can't spend it until we've had formal confirmation because it was too high risk. So it's been a little bit variable depending on the allocation, depending on our level of confidence of receiving it. But we do know that there are some areas. So one of the big areas for us has been the mental health outcome monies, and that has reduced quite significantly for all the boards. So there's a concern there, and we had tried to make sure that we were reasonably safe in that. But obviously that does mean that we don't have the same level of funding to deliver it on the outcomes and the plans that we had put in place previously.
Sorry, sticky mute button. Thank you, Heleth. Okay, I'm not seeing any other questions or comments. Obviously, we are still in a position where we have our FRP meetings monthly, to make sure that we can give this the attention and scrutiny that it requires, and that is carrying on. I think our next one is next week, isn't it? Yep. But it's helpful to bring it here so that board members can see that in its entirety as well. So we are being asked to examine and consider the implications of the report, and we are limited assurance is being proposed for this, just because of the position, obviously. Are members content with that? Okay, super. We are a little bit ahead of schedule, but I'm going to give everybody a bit of a comfort break just now, because the next item on the agenda is the IPQR. So I need you all fully fueled and refreshed for IPQR interrogation. So I'm going to propose that we take a 15-minute break, and I will see everybody back here at 11 o'clock, please.